This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard, a cardiology specialist of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to MyHeart.net, and today we're going to talk about embracing your genetic blueprint and exploring inherited cardiomyopathies. And this is a follow-up on the podcast we had on genetic testing, particularly as it relates to cardiac disease. With us today, we have Dr. Pankaj Arora, who's director of the Cardiovascular Genetics Clinic Program, director of the Clinical and Translational Research Program. He's also associate professor of Division of Cardiovascular Disease in the Department of Medicine at UAB. So, Pankaj, thank you very much for taking the time and being with us today.
Thank you for having me, Alan. It's a pleasure.
Well, we talked a little bit about genetic testing on the former podcast. Today, we're talking about some of the examples of inherited cardiomyopathies. We know that there's probably over 10,000 different types of single gene disease. That means monogenic disease that is caused by mutation of a single gene. It's estimated about one of every 100 patient is affected by this. So this is quite common, and it's really a field that is really kind of like really developing in the area of genetic cardiology. And, if you don't mind, Pankaj, maybe we could start with discussing some of the dilated cardiomyopathy. And by that, we mean the left ventricle that are enlarged, the walls of the heart that are being thin, and with the heart function being reduced. We know that normally a heart function, the heart pumps about 50 to 60% of the blood with each contraction. So these are patients that have ejection fraction in the range of 20 or 25%, or sometimes even worse. They can be quite symptomatic or sometimes have no symptoms at all. But let's talk about inherited cardiomyopathies as it relates to dilated cardiomyopathy. Pankaj.
Yeah, thank you, Alan. As you correctly pointed out, dilated cardiomyopathy evaluation in 2023 has completely undergone this paradigm sort of shift where we are thinking that the disease itself is a broader bucket, and there are multiple sort of smaller diagnoses that can be put into this. So just to give our readers some idea or listeners some idea, every heart can become dilated in the end stage, and whether the heart that has become weak due to blockage in the heart arteries, or the heart that is now weak and never had any coronary artery disease or never had any traditional sort of non-ischemic cardiomyopathy, which in Southeast is really due to hypertensive heart failure or high blood pressure or diabetes. So if we leave those out, then we are left with dilated cardiomyopathy, which is really a genetic disease. And a genetic cause can be found at least in up to 50% of these cases. And genetic testing is very sort of advisable. It's class 1. In the European guidelines that are just out there, it's really the first, it's like to go. And many of these genes, as you said, these genes are expanding. The list of genes is expanding. We back a decade ago, or maybe even more back, these were 20, 50 odd genes. Now in any commercial gene panel, there are more than 100 genes that we have been sort of looking at. And that list is growing because science is evolving. And these genes are really determining the structure and the function of the heart muscle, and can involve any of the components of the heart muscle, such as sarcomere, desmosome, nuclear lamina, mitochondria, and ion channels. So if you think of a patient with dilated cardiomyopathy, he or she may have genetic variation or genetic mutation in any of these structures or components of the heart muscle, and then having having a variation usually causes the heart to sort of expand, become dilated, function goes down. The most common gene and the first gene that has been studied in the DCM space is the titin gene. Titin is a very big gene, and there are multiple pathogenic and likely pathogenic variants that are described in ClinVar for titin. And then depending upon the location of the variant, whether the variant is in the A band, and where it is really located in the chromosome, you could say that the variant would have an impact on the splicing and change the protein. So we there are tools to functionally annotate the variants. Sometimes these annotations are given to us by the gene panel companies, and sometimes we have been trying to annotate some of these variants, at least in the titin gene, by understanding how much difference does it make on splicing. Some of the other genes, for titin, the patients progress to severe heart failure, will need a VAD or a transplant at an earlier age. And we have really seen bimodal presentation. We have younger patients with titin and they have progressed severely. And we have patients in 6 and 7 decade with titin variants, and they are doing so far okay on regular GDMTs. There are drugs, there are phase 2 trials ongoing for the titin variant DCM, and we hope that the results will be out sometime next year, and there will be a medicine that will be focused on titin dilated cardiomyopathy patients. Then for the LMNA, which is a disease that can really be related to the protein A of the nucleus, and this type of genetic DCM has 100% penetrance and can present with malignant arrhythmias. Most commonly, our EP colleagues are the ones that will see the patient, either in the community or they'll be putting the devices, and then the patients get they get referred to us. And these patients, they can present with VT storms, and they will require VT ablations and ICD therapies, and then really guideline directed therapy have been sort of the goal in LMNA DCMs. We don't have gene therapies yet to treat LMNA DCM. We hope in future it will be. And then some of the other big ones can be really the SCN5A cardiomyopathies, the channelopathies, and affecting the cardiac sodium channel, and they present with arrhythmias. The KCNQ1 is a long QT that we see, and we have been seeing a lot of patients with familial atrial fibrillation, and that is in younger people as well. And they have variation in the DCM genes. And some of these, they are seen in the community by, as I said, by either our general colleagues and then our EP colleagues, and that's their first presentation to the health system.
It's very interesting. I have a wonderful patient. She's 52 years old, and she has the LMNA, gene mutation as well as the next gene, and she, everything started for her. It was about 2009. She was in her 30s, and it started. She went to UAB and got a defibrillator, and then she followed up with me. And then 6 years later, she developed this VT storm and upgraded, her ICD to BIV-ICD, and even enrolled her in some stem cell, treatment. And she's been doing well now in guideline medical therapy. So interestingly, her son, developed, had the same. She has one son, and he's 18 years old, and he presented with he was followed by a pediatrician, and then developed this, cardiogenic shock, and it was really kind of in trouble. Was admitted at Children's Hospital, and survived. He was treated for his cardiac, congestive heart failure. Even underwent, cardiac transplantation, And this patient has been so instrumental in really trying to kind of work with geneticists and genetic counselor, trying to get all of her family tested. And even the pediatrician mentioned that if we had known, for example, that her son carried that gene, they would have had probably a closer follow up with him, maybe with echoes, so that possibly it could have avoided this dramatic presentation in cardiogenic shock, being admitted like this and had to undergo heart transplant. I mean, maybe it would have had to undergo cardiac transplantation anyway, but I think it's so important this situation where you have very high penetrance, of the gene doing cascade, testing is so important to get the family involved. And she's having a lot of problem with some of her siblings not wanting to be tested or not wanting to know, whether they carry the gene and so forth. And I find that so unfortunate, but she's a true champion, at least in her family, trying to really kind of work with the team and really trying to prevent what happened to her son.
Yeah, I think with the LMNA mutations, it is really, as you know, it can affect other organ systems as well, such as muscle weakness, muscular dystrophy. The fat distribution can be abnormal, the skeletal abnormalities. So it is really important for LMNA carriers to be seen in the inherited cardiovascular clinics. I can't stress any more on this. These are the families, they should really be seen at specialized centers because of the variety of organ system. It's a multi-system disorder, and they should be seen and followed up closely.
Right. Let's talk about the hypertrophic cardiomyopathy, which is almost, the opposite, where we have the problem that there's too much heart muscle. I mean, the left ventricle is really hypertrophied. The walls are thick. If you calculate the LV mass, it's about 400 to 500 grams, when normal should be just 100, to 150. So these patients really sometimes they can present that they could have obstructive physiology, and they really kind of decrease the outflow tract. Some patients can even pass out when they present. They present with syncope. Some others are non-obstructive completely, and it's so difficult for us to differentiate. Is this kind of a hypertrophic cardiomyopathy? Is this secondary to hypertension, or is this, as we're going to talk later, something that looks like it, but it's an infiltrative problem?
Yeah, hypertrophic cardiomyopathy, Alan, is very close to my heart per se. Really things have changed completely since the therapies have now been made available. You pointed out very correctly that living in Southeast, you see a thick heart, and we teach our fellows a thick heart is due to hypertension until proven otherwise. And the rates of high blood pressure are 8 out of 10, and patients don't take their medicine. So really the echo cutoff of 15 millimeter or more, and and the ratio of the septum to posterior wall, or individuals with positive family history, and giving them some leverage on how thick their muscle is. That is the clinical sort of conundrum in HCM space. So really, how do you make sure this is not hypertrophic or a thick heart due to your hypertension or kidney disease? And there, I think genetic testing, especially when they have family history, becomes very important, because if you come to think of HCM can be your traditional septal hypertrophy, your mid-wall hypertrophy, your apical HCM. So you can have, with as you know, with hypertension you have your concentric LVH, but then with these classical HCM patients, you can have hypertrophy anywhere in the heart, and their presentations are very different. For example, if they have apical HCM, they almost always, if you look at studies, they don't need ICDs, but they almost always have atrial fibrillation. And I was talking about South Asian descent, so their genetic makeup, or they have a specific 25 base pair deletion and have apical HCM. So they get picked early on. You have this big, deep inverted, waves on the EKG, and you show it to a fellow, he gets excited, and then this is a classic case of apical HCM. So apical HCM at least gets declared outside the echo lab, some by EKG. But other forms of HCM, a negative EKG really doesn't mean much. So then you come to your second line, which is your echocardiogram, and then your echocardiogram done correctly, measurements obtained correctly. And then you could also argue, Alan, that these are non-contrasted measurements in the guidelines, and most of our sort of practices, we are using the ultrasound enhancing agents, and the thickness looks very different on contrasted images and non-contrasted images. So after you've done all that and you have recognized this is meeting the criteria for HCM, then is where we come into play. We take the family history, we draw the 3-generation pedigree, and we recognize the hypertrophy where it is. And then you spoke about gradients. We are very gradient centric in 23 right now, but in 24 and year 25, I think that will go away because the disease is not gradient centric. The reason we are gradient centric is because the therapy is approved in a manner that we are following it. So we do the rest ultrasound, and then we provoke the gradients, and many of our patients, they're not able to do Valsalva. The elderly HCM, they are not able to bear down, and then we have to come up with ways to get that, to provoke that gradient, and we put them either on a treadmill or a bike, and then we have stress protocols written so that we could do the peak Valsalva evaluation very carefully in these patients. And once that is done, we understand that either they are obstructive or non-obstructive, both at rest and provoked. And if they are both at rest and provoked, they're non-obstructive, then their symptoms really is due to that hypercontractile sort of apparatus, the actin myosin apparatus that they have. In those cases, if they test positive, it's very easy. Right now, we put them in the clinical trial, which is testing the non-obstructive HCM. And if they test negative, if they test genetically negative, and they sort of don't want to either get enrolled in the clinical trial, we follow them with regular GDMTs. For the obstructive HCM, the therapy is sort of out there. We have to put them in a protocol, follow them every 4 weeks. So they get their medicine 4 weeks, 8 weeks, 12 weeks echo, and then echo every 12 weeks. And we closely follow their symptoms and gradients. And this has completely changed the way that septal reduction therapies, as you are well aware, Alan, there were 2 treatment options. One was your surgeon going in and chopping a piece of the heart. Didn't go very well for many patients and not for many surgeons as well. And then the other was, us putting alcohol in the cath lab, which is easy to do. But again, pacemaker implantation rates are, so the morbidity in general with both these procedures is very high. So now I think we are coming closer to a time that medication is the first line therapy for obstructive HCM. And this is a moving, very fast moving field as well. And we'll see these changes in the guidelines soon.
What about the patient that's presenting with sudden death?
Yeah, so that is that patient in itself, you can imagine has a lot of fibrosis. If there was a MR, has a lot of LGE on the cardiac MRI, and definitely needs an ICD. Now that patient has survived. Now the question is, if it is non-obstructive HCM, or let's say that patient presented with sudden death, came to the hospital, and we have many such patients at UAB, underwent ICD, underwent septal myomectomy, and now we are seeing them in the clinic. And if it is still non-obstructive, we undergo this discussion about mavacamten, where we say the regression of hypertrophy. Is that really a phenomenon? And in some of our earlier ones, we are seeing it. This is one site experience, but we have started seeing that regression on serial imaging. And I think as time passes by in next couple of years, this data will be very clearly sort of available. I've also seen some data around VTs and events going down with the medicine, and I've seen that both for Entresto and for mavacamten, and it is interesting to offer some of these goal-directed therapy to our SCM patients.
Well, let's finish by talking about the great mimicker, and that's amyloidosis. Amyloidosis keeps throwing curveball at me. I had a patient a few years back, had hypertrophic cardiomyopathy, and with a very, very strong gradient. It was obstructive. I sent her to surgery for a septectomy. That means that they remove part of the septum to relieve the obstruction. She did great, except at pathology, it was amyloidosis. And it was AL amyloidosis that I had to refer to an oncologist, and she's been treated ever since and doing well on Velcade. That's patient number one. Patient number two is a patient that has non-obstructive cardiomyopathy, very, very thick walls. And I'm doing, for example, well, some of the protein, were negative. I sent to an oncologist. I did also a technetium study that was highly suggestive of amyloidosis. I did even a cardiac MRI that was also highly suggestive of amyloidosis. And the oncologist sent her to Vanderbilt to get a muscle biopsy negative for amyloidosis, and even did some genetic testing that was also negative for that. So I'm almost like, throwing my hands on amyloidosis. Very kind of a difficult and tricky disease, diagnosis to make. There's it's really kind of an interesting disease. What's your experience, and how can genetic testing can help us make the difference?
I think amyloid is an under sort of recognized problem. I think the prevalences that we are seeing in the literature right now is going to move very quickly from what we think it is to what in sort of it's the major bucket. And this is I have this bias because I see lot of amyloid hereditary TTR, and if you look at the literature, the phenotypic expression of hereditary TTR in population cohort studies, and we have done a paper on this as well from regards population, is really around after 60s, in the sixth and seventh decade, when they develop cardiomyopathy and heart failure. And I have a sort of a decent sized population now in the clinic where we have amyloid cardiomyopathy, TTR variant positive African American individuals, because this variant is commonly found in 3 to 4% of the African American population, VAL 122I, which is really causing or really responsible for the misfolding of the protein that gets deposited into the interstitial space, and it causes the cardiac cells to first stiffen up, and then then the function goes down. So thick heart, it really depends on where you catch the patient. So the diagnostic dilemma that you described is, at what sort of stage did you see the patient? You are very correct. It could be an HCM mimicker, and in your echo lab, the apical sparing of GLS may help. But it could be that you have a burnt out amyloid and it is a 30-35% EF that you are seeing in the practice first time. So I think it's not unusual to keep thinking about amyloid and the stage of where your patient is in the curve, so to speak. The hereditary ATTR, this has also undergone like a huge shift, Alan, because of treatment, both the tafamidis and the siRNA therapy, the Amvuttra, and the siRNA currently is only approved for hereditary ATTR with neuropathy. And the cardiomyopathy indication is going to get approved shortly. So the treatment is expanded. So what we can offer to our amyloid patients has grown. When I was a fellow, Alan, I was taught if your amyloid, TTR amyloid, has 30% EF, they have 6 months to live. And they are going down, and they're going down fast. And we don't have enough organs in the US to give it to everyone, let alone our amyloid patients. So I think here also that the expansion of the treatment that has happened has made this whole sort of area and amyloid program under the inherited cardiovascular disease program that we have very interesting, because we work them up in a systematic fashion. So we first try to make sure we have a clear distinction between AL and TTR amyloid. And once we are in the TTR space, whether it is hereditary or wild type, and we have a scientific paper that we have worked on from all of us, where we have went after carpal tunnel syndrome, and how can you pick patients presenting with neuropathy in 150,000 all of us participants and think about which one of those are amyloid. So starting with something very benign, which is 10 years prior to the heart failure, and thinking about is that an approach to find these patients early, because we don't want to treat them when they are end stage heart failure. We want to treat them early. We want to even treat the pre-disease, and I think that will be reflected very quickly in our updated guidelines.
Well, we've talked about dilated cardiomyopathy, hypertrophic cardiomyopathy, and the great mimicker amyloidosis. Pankaj Arora from the University of Alabama, thank you very much for your time.
Thank you, Alan.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.